Hi, this is Dr. Tim Conley at Yeshiva University, and we're going to process the mock case, the evaluation of a client that we're calling Michael Parker. Mike was a client of mine a number of years ago. All the identifying information has clearly been scrubbed out and changed, but nonetheless, one thing Mike had always said is you should teach about guys like me. So I have donned my Hawaiian shirt out of respect for the client's preferred mode of dress, and let's go ahead and tackle what we can, some of what we can learn from the Parker case. So, 49 years old, married, Caucasian guy. He was sent by his attorney. The attorney called and said, I have a client. I don't know if you can deal with it, Tim. He's a steaming hot mess. I'm like, okay, that's one way to describe it. We try to avoid that kind of terminology in clinical social work, maybe behind closed doors. We have our humorous moments, but be sure to always show respect for the dignity and worth of people. He's, at any rate, he was in trouble. He had a lot of things going on. Felony, one thing Mike had said is of every low down, dirty, rotten felony criminal charge I've ever done in my life, they wind up sentencing me for methamphetamine residue on a bag. On a baggie. They got him on a felony charge for methamphetamine based on a residue on a baggie. And he, in confidence in therapy, disclosed many other things that he had done in the course of his life it almost felt to him, you got me on this penny ante little stuff when you let me go on all these other things. At any rate, in this case, the client was seen as part of a home visit. He was not mobile at the time, was too ill to travel, had no way of getting back and forth, and his residence was in between two offices, and so he was actually seen in situ in his natural environment. And he was accompanied by his fiancee, Melanie Smith, who, as it later turned out, had bipolar disorder. She was in a fairly stable place when we did this evaluation, but eventually had some very severe manic episodes, including psychotic break. So he acknowledged his use of meth. He said that he had never been into the drug with much frequency, and but he has recurrent seizures suffered since he received the TBI. So we've got a couple of things here we're in diagnostic mode, right? We're assessing, evaluating what's going on. Well, he has a TBI, so we know that there's some brain involvement anyway. Now, nobody who has a traumatic brain injury history and recurrent seizures should really be using any mood or mind-altering substance outside of what is prescribed by their physician. So he's kind of meeting the diagnostic criteria of having a medical condition that is caused or exacerbated by the use of the substance. Look that up in your DSM 511 criteria. He has the TBI and his substances are using, so we have criteria met. There's one. Okay, and we do this with each of the diagnostic criteria. We want to interpret the client's experience through the lens of, do they have the diagnosis, and of the diagnostic criteria that they have, how are we going to treat those? So he said he's only used meth a handful of times, but other stuff, cocaine, marijuana, he had grown up in the late 70s, 80s actually, and alcohol was his chemical of choice. And he had a history of driving under the influence of charges, possibly 3 in California, but he has difficulty with memory. You have to think, has the alcohol progressed to the point that it's impaired his memory? Well, between the TBI and the alcohol saturation in his brain, there definitely were some memory issues. There was a motor vehicle accident in 98. He got his disability benefits, etc. He had neurobehavioral evaluation, which confirmed that. And he also carried with him from previous evaluations a major depressive disorder, anxiety disorder, PTSD secondary to his experiences in the Gulf War. Bipolar disorder, which I ruled out later. I saw no evidence of bipolar mood swings. And panic disorder, which again, I saw no evidence of. Those were, I'm not sure where he picked those diagnoses up, but here's a teaching point for you guys. When you receive a record, it has a diagnosis, from several years ago, I think it was 7 years ago. Perhaps at the time that he was seen in that facility by that person, he was exhibiting symptoms consistent with the bipolar disorder, but it's not for life. The diagnosis is what do you have in front of you, what's going on now. Call it in remission, called it ruled out, called it not current active. I wouldn't actually put it on the evaluation that he had the bipolar disorder. I don't think. Let me look down below and see if I did. Memory serves, I did not. He has had difficulties maintaining his mood. He had grief, so we've got TBI, we've got chronic alcohol dependence, we have post-traumatic stress disorder from Gulf War experiences. Now we have grief from his brother's death, his mother's death at the same time. Those eventually became a real focus of therapy. And he's had significant losses in his life. So grief was a large issue. He had hospitalizations. The epilepsy or seizure disorder was from his TBI, obviously exacerbated by his relapses with alcohol because it undermines the effectiveness of his seizure medication. So watch what are the medical drug interactions is what we're after. What are the med interactions? What does alcohol do to the other meds that he's on? Let's see, where are we going with Mr. Parker? He could not find transportation. He was not able to drive. Said he was unable to afford his meds, but he did receive a substantial inheritance. We're talking $500,000 from his mom, which was put in trust because she knew of his condition. So he had a trustee in order to access his money. They were paying it out to him, but it was really their decision when he got funds and when he didn't. And, he has gout, has degenerative joint disease or disc disorders, etc. Wasn't suicidal, seemed pretty happy, was kind of a good time guy, and, liked to drink heavy. He knew that he needed to quit. So we gave him a variety of tests, mental status exam, etc., etc. I am going to trust you to read about all of those, written up extensively in this report. The substance abuse subtle screening inventory was used, utilizes a number of items taken from psychological screening inventory, gauges his level of defensiveness, etc., etc. So all in all, he is fairly open, forthcoming about his chemical use, much less insightful about how devastating it's been for him for his last 30 years. He doesn't readily remember the impacts of his alcohol use on him. The depth of his insight was really kind of quite limited. He thinks I can handle one a day. I should be able to drink a little bit. He wants to go back to a time when he could drink just a little bit. So let's get into the dimensional placement criteria, a bit of a organizational issue on the report here as it copied over from a Word file. But you see that dimension 1, he doesn't appear to require detox at the time, but it's possible that he would need a medically managed level of inpatient were he to continue to drink as heavily. Dimension 2, he has biomedical conditions, obviously the epilepsy, the TBI, etc., etc. He's engaging, he's pleasant, but prone to severe episodes of mood instability, does not really cope well. He was in need of a good deal of support and hopefully was going to get that through ongoing treatment. His readiness for change was, back up there. He self-medicated. I mean, he considered, like so many people with addiction, the substance I'm using is not the problem, it's the solution. This is the way I cope with all of this other stuff in life. There are reasons I drink, the reason for this, the reason for that. If you were me, you would drink too. There's no other way to get through the day. Be careful not to get caught up in that as a clinician. The clients will want you to start mucking around in their formulations of what are going to be the solution to their problem. And with social workers, we can get pulled into that, into wanting to meet the client where they're at. Be careful. We're dealing with someone who has perhaps a delusional belief system, a delusional perception of the world going on here. His ability to, accurately remember and report behaviors is compromised. And he'll be more than glad to want to talk about the grief and the war and this and that and the other thing, which will keep you from talking about, it's not the alcohol that, the alcohol is causing your current problems. Let's deal with what's going on currently and what you can do about it. And an individual who's drinking and continuing to drink is never going to be able to engage in meaningful psychodynamic psychotherapy, family therapy, whatever model you're using is going to require a more sophisticated use of all of their faculties. It requires the use of all of our faculties. And as long as they're substance impaired, you can't go into those underlying causes. There's this assumption on the part of many clinicians, if we get to the underlying problems, like in this case, that then the drinking will go into remission. It's not how it works. The drinking has to go into remission before you can do any meaningful psychotherapeutic work with a case like Mr. Parker. His readiness to change was far from optimal, very chronic, but he is fairly easily influenced and guided by those around him, and we hope to use that as advantageous pro-social and therapeutic manner. Perhaps group therapy. I think if he's in with people who are at a motivated level of stage to change, he will catch on. He described himself as a creature of environment, and he likes to pick out, party substance-using addicted environments. And perhaps if we put him in a more pro-social recovery environment, he'll do well. But he's very high on his potential to relapse. And, the price of relapse is pretty high. So we're, our diagnostic impression, what did we go with the bipolar? I don't think I see it there. Major depressive, anxiety disorder with a history of panic, PTSD, alcohol use disorder is obviously severe. We're looking at personality disorder, primarily with dependent features. It's secondary to his TBI. A little beyond where I want to go in this lecture, but there is some personality disorder stuff going on there that we should look at in the long run. A long history of antisocial behaviors. Seizure disorder, obviously, and frontal lobe problems. I didn't go with any of the mood stuff, but recommendations are pretty clear. He's going to need to be seen pretty consistently for quite a while. He may need a higher level of care, like inpatient, et cetera, but he needs to be case managed and needs to, he could be managed in the community. I think the court system was trying to decide whether to incarcerate him. Was he a danger to other people? If properly managed with enough outpatient therapy, the conclusion was that he'd be able to be seen in the community. So there you have the case of Mike Parker. Hopefully you can see how this ties into some of the reading we've been doing on different substances and find this case to be as instructive as I did when I worked with this individual.